I'll continue off where I left off with tuberculosis of the hip, and let's see what happens after that. There's a lot of things I need to do, but I need to still do surgery. I have to start with surgery, to be honest. I haven't even touched surgery till date, and surgery paper has been my worst paper till date. So I really don't know how long I need to lock in. 2 days I need to. So we start with tuberculosis of the hip. So pathology, it is an initial lesion in the bone adjacent to the joint. So rarely the lesion may begin in it. It may begin in the synovial tuberculosis, which is seen in the knee joint. But if there is infected granulation tissue, it erodes the overlying cartilage or the bone and reaches the joint. That's basically how the tuberculosis of the hip occurs. So multiple cavitation will be formed inside the femoral head and the acetabulum, and they constantly pull the muscles acting on the hip. Femoral head will dislodge from the acetabulum and give rise to wandering acetabulum. Femoral head will come out and wandering acetabulum will be seen. Then clinical features, you have pain, stiffness, deformity of the hip, cold abscess, and discharging sinuses. So investigations, you can perform X-ray examination of the pelvis with the both hips, and MRI scan you can do, and bone scan you can do. So examination, so that was investigation. X-ray, MRI, bone scan. Examination you can do standing with compensatory exaggerated lumbar lordosis. They'll be standing with a lot of lumbar lordosis. They'll be having a stiff gait, forward and backward movement of the lumbar spine is used for the propulsion of the lower limb. So they move with the lower limb. Painful arthralgic gait will be there. Limb is exaggerated by pain. They will not be able to take the weight off the affected side. They can put weight on it, but they cannot take it off. So muscle wasting will be there. Thigh muscle and gluteal muscle will be wasted. Swelling will be there due to the cold abscess. There will be discharging sinuses. There will be deformity. There will be shortening. Except in stage 1 where there will be lengthening. First there will be lengthening, then there will be shortening. Deformity, discharging sinus, shortening. Okay. So stage 1, synovitis or apparent lengthening. Effusion into the joint will occur, and effusion makes hip to be in position of maximum capacity. Flexed, abducted, and externally rotated. It will just put pressure on the bone, and it will make it that it is flexed, adducted, externally rotated. Okay. So abduction deformity compensated by tilting the pelvis downward. They will tilt the pelvis downward. This causes the apparent length to be increased, and measuring true length, the two limbs will be found to be equal. Then you have stage 2, which is arthritis or apparent shortening. So articular cartilage is involved in this. This leads to spasm of powerful muscles around the hip. Since the flexors and adductors are stronger muscle groups, hip takes out the attitude of flexion, adduction, and internal rotation. It is opposite of adduction and internal rotation. It is still be flexed because of spasm of muscles, arthritis, and apparent shortening. This is compensated by pelvis tilting upward, whereas before it was tilting downwards, now it will tilt upward. It appears shorter. Apparent shortening is there, and measuring through limbs, both are found to be equal. Then finally you have stage of erosion. Head and acetabulum eroded. Articular cartilage is also destroyed. Articular cartilage is gone. Head and acetabulum is eroded, associated with pathological dislocation of the subluxation of hip. It will dislocate, as we have told right here. Wandering acetabulum will occur, and it will dislocate or subluxation of hip. And you have exaggerated flexion, adduction, and internal rotation is seen, and true shortening of the rim occurs because of actual destruction of bone. Actual bone is destroyed, therefore it will be shortening. Radiological signs, you have haziness will be there, light occlusion will be there. There is a reduction of joint space due to destruction of cartilage. There is irregular articular outline. Articulation outline will be irregular, wandering acetabulum as told. There will be signs of healing and sclerosis around the hip. There will be some healing and some sclerosis. And differential diagnosis. Other causes of monoarthritis of the hip should be ruled out, like low-grade septic infection and rheumatoid arthritis. Inguinal lymphadenopathy or psoas abscess can be seen. Congenital dislocation of hip, congenital coxa vara, Perthes disease, and osteoarthritis all can be noticed. So treatment can be provided as tuberculosis of hip, anti-tubercular treatment below the knee, knee skin traction you have to give. There may be relief of symptoms and signs. You have to repeat the exercise to evacuate the state of joint destruction. Keep on repeating the x-ray and you can evaluate the state of joint destruction. There is no or minimal joint irregularity. You can mobilize the hip and you can so that most of the function, as much function as possible, can be gained. If there is severe joint dislocation or subluxation, you can do normal joint function will not be possible. So if movement at the hip is desirable, you have to do girdle stone arthroplasty. If stability of the hip is desired, then you have to do fusion. By conservative methods, you can do spica, or by operative method, arthrodesis. Basically amputation of the hip. Amputate the hip, put a hip spica, girdle stone arthroplasty, which is most often needed. You can do mobilization of hip to provide this. Okay, so ATT, below knee traction you have to give, relieve the symptoms and sign. Repeat the x-ray to see what happened to the joint. If there is no joint irregularity, mobilize the hip, gain as much function. That's it. Okay. Tuberculosis of the knee might not be required. Okay, this is root of tuberculosis of knee pathology. It is a disease beginning in femoral or tibial condyles, osseous TB or membranous TB, synovial tuberculosis it may be. Disarticulation of articular cartilage and bone is seen. Synovial effusion and pus will be formed. Joint will be distended. Destruction of ligaments is there, and tribal subluxation is seen. Pus may burst out of the capsule to present as cold abscess and finally sinus. Okay, so synovial effusion is there. Pus will be formed. Joint will be distended. Ligaments will destroy, and tribal subluxation. I think tribal subluxation is flexion, posterior subluxation, external rotation. I think so. So clinical feature, clinically the age group of 10 to 25 years, most commonly affected. Pain and swelling in the knee is seen. Severe stiffness of the knee is seen. Examination, you can have swelling due to synovial hypertrophy. The joint will be hypertrophied or effused. Muscle will be atrophied. You can form cold abscess and sinuses will be there. So deformity will lead to triple displacement. Any deformity will lead to triple displacement, wherein you have flexion, posterior subluxation, external rotation. Due to ligament laxity, the ligaments will be lax, therefore it leads to all this. There will be limited movements at the joint. TB of the knee, disease begins in femoral or tibial condyles, osseous TB or synovial membrane, synovial TB. Destruction of articular cartilage and bone is noticed. Pus may burst out of the capsule, so pus will be formed, joint will be distended, ligaments will go, triple subluxation will occur, flexion, posterior subluxation, external rotation, and pus may burst out, cold abscess and sinus. So 10 to 25 years, pain and knee swelling in the knee will be there. There will be severe stiffness of the knee. There will be swelling due to synovial hypertrophy or effusion. Muscle atrophy, muscles will be atrophied. Cold abscess and sinus will be there. Cold abscess and sinus, and limited movement will be there at the joint. So investigations, you have radiological investigations, examination, which is diffuse osteoporosis of the knee, bones around the joint. Osteoporosis may occur to the bones around the joint. Joint surface will be eroded. There will be triple subluxation and cavitary bone lesion. Bone lesions with cavity will be seen. Then Differential diagnosis: pathogenic infection. It may be the monoarticular rheumatoid arthritis, chronic traumatic synovitis, and hemophilic arthritis. So treatment, you have to ATT and skin traction is provided, relieves the muscle, and you have to relieve the muscle spasm. Repeated X-ray you have to do. If there is severe joint destruction or subluxation, then reasonable joint function is not possible, and if you desire stability, you have to achieve fusion of the joint by conservative methods or by operative methods. So operatively you do arthrodesis, which is compression type, and conservatively you do long leg cast fusion till fusion occurs. Of course, the other one was joint mobility is normal, then you provide mobilization and achieve mobilization as early as possible. Then we have CTV, but I'll come back to this. Okay, give me a second, because to do, you have to do what do you call this, trauma you have to do, and you have to do CTEB. Now there are things which I have to revise, do again, and those things are what I have done from now. So whatever I have done till now, I have to revise again, because they are all very much important. Page 47 onwards, they are the main questions which they can ask. So this one I'll try to finish osteo all the diseases of the bone. Okay, then I can do arthritis diseases, metabolic diseases, rickets, osteomalacia, Perthes, torticollis. So I need to finish from around 20 pages. This will take an hour, but honestly this is not that big as a problem, as big of a problem that trauma is, even though it's like 47 onwards. So it's like from page number 20, it's from page number 22 to just 47. That's just 20 pages, but it's so much. I have to do it so many times. I need to do it again. Trauma is really very difficult to remember. Okay, from this till 30 is okay. So let's see, I think I may have to do trauma again. I put a question mark. On the day of exam, starting part. So I will need to revise it. I will need to do trauma and CTV is okay. Okay, I'll do till this end, and then trauma again. That will take another hour, and after that I will start with surgery too. Fine. Okay, so congenital dislocation of hip and other malformation. So etiologically, it is a hereditarily predisposition to joint laxity, that is congenital dislocation of hip. So hormonal induced joint laxity, you have maternal ligament relaxing hormone which crosses the placental barrier. You can have breech malposition. So types of dysplastic hip, you have those displaced at birth, classic congenital heart disease, and those displaced after birth. So examination, you can do Barlow's test or Ortolani's test. You have limited abduction of hip, asymmetrical thigh folds will be there. Galizzi's test. Do we have? Oh my god, they don't talk about these tests. Fine. It's very important to learn them. I will do something. Trendelenburg's test you have to do, and telescoping will be positive. Unilateral dislocation is Trendelenburg gait. The bilateral dislocation will have waddling gait. This honestly is do from TB. I will do something about it. Wait. Congenital dislocation of hip. This is really not enough. Congenital dislocation is such a big topic, and there are so many important questions. So it can also be coxavera, posterior hip dislocation, and paralytic hip dislocation. Hip dislocation commonly. X-ray, you will have delayed appearance of ossification center of the femur. There will be retarded development of ossification center of the head of the femur. You will be having sloping acetabulum. Acetabulum will be sloping. You will have lateral and upward displacement of ossification center of femoral head, and you have break in the Sheraton slide. So methods of reduction, you have frog leg or Lorenz cast, bachelor's cast, and one Rosen's splint. So congenital dislocation of hip, if they can come at birth or they can come after a few years. If it is at birth, you have to do close reduction. If it is successful, you maintain it in cast number A for 3 months, which is frog leg. So, and you provide a brace. If the acetabulum develops, you remove the brace and you do physiotherapy. If it does not develop, then you do reconstruction and then you do physiotherapy. If close reduction itself is not successful, you have to provide traction, and you have close traction. If it is successful, then you treat with a cast. If it is not successful, then you treat with B, which is close reduction. Usually, if it's not possible as they come in late, you do open reduction and acetabulum reconstruction, derotation, osteotomy. You have to do all those. Then you have Spiegel's shoulder, wherein the scapula is developmentally a cervicular appendage. Failure of descent of scapula leads to congenital high scapula, which is known as Spiegel's deformity. Then triple deformity of the knee, it is PRPP, post polio residual paralysis. So you have flexion, posterior subluxation, and external rotation. Flexion, posterior subluxation, and external rotation of the knee. That is triple deformity of the knee, FEP. FEP. Post polio residual paralysis, flexion, posterior subluxation, external rotation. Okay. So then bone tumor classification, you have bone forming tumors, cartilage forming tumors, giant cell tumors, marrow tumors, vascular tumors, others, and tumor like lesions. So bone forming tumor, you have in benign, you have osteoblastoma, osteoblastoma. In aggressive, you have osteoblastoma, and in malignant, you have osteosarcoma. So in cartilage forming tumors, you have osteochondroma, you have enchondroma, you have chondromyxoid fibroma and fibroblastoma, but these both are more than enough. Osteochondroma is more than enough. And in malignant, you have chondrosarcoma. Chondroma is benign, enchondroma, osteochondroma, benign, malignant is osteochondroma, chondrosarcoma. Benign in bone forming tumor, osteoblastoma and osteoblastoma. Malignant, however, osteosarcoma is very much malignant. Then giant cell tumor, you have benign, indeterminate, and malignant. Marrow tumors, you have Ewing sarcoma, plasma cell tumor, multiple myeloma, and lymphoma. You can remember it. And vascular tumors, you have benign and you have malignant. So in benign, you have hemangioma, glomangioma. And in malignant, angiosarcoma is always malignant. Hemangioma is not malignant. Glomangioma is also not malignant. However, angiosarcoma is always malignant. So others, you have benign neurolemoma and neurofibroma, and malignant fibrohistiocytoma and liposarcoma and adamantinoma can be seen in malignant. Neurolemoma and neurofibroma, they affect the neurons. Okay, so bone cyst like, what do you say, bone cysts, tumor like lesions. You have bone cysts, you have fibrous dysplasia, you have giant cell granuloma like epulis. Fibrocortical defects also can be there. Eosinophilic granuloma also may be seen. Fibrous dysplasia is one important thing. Giant cell granuloma with epulis and bone cyst. Okay, leave it. Then osteosarcoma, osteogenic sarcoma. It is the malignant tumor of mesenchymal cell characterized by formation of osteoid or bone by the tumor cells. Bone by the tumor cell. So you have types. You have primary osteosarcoma between ages of 12 and 25 years, which is not associated with pre-malignant conditions. You have secondary osteosarcoma by the age of 45 years, which is associated with pre-malignant conditions. You have Paget's disease. You have multiple enchondromatosis. You have multiple osteochondroma. You have fibrous dysplasia, and you have irradiation to the bone. Irradiation to the bone, fibrous dysplasia, multiple osteosarcoma, osteochondroma, multiple enchondromatosis, Paget's diseases, all of them are secondary osteosarcoma, which is malignant. Osteosarcoma is malignant. Multiple enchondromatosis, osteochondroma, which are benign lesions, will become malignant osteosarcoma. Fibrous dysplasia, of course, and irradiation to the bones associated with pre-malignant conditions. Secondary is pre-malignant conditions will be there, but in primary it's not there because it is very early, you can see. So classification, it can be osteoblastic, bone formation will be there, chondroid with the cartilage formation will be there, fibroblast formation will be there. It can also be telangiectic or osteolytic. So common sites is at the lower end of the femur, at the upper end of tibia, and at the upper end of humerus. Those are the common sites. So investigations, you have chest x-ray. What am I saying? Chest x-ray. X-ray will show areas of irregular destruction in the metaphysis because it affects most commonly metaphysis. And new bone formation in the matrix of the tumor will be there. Periosteal reaction can be seen. Periosteal reaction is because it will be rising up. Periosteum will be rising up. Codman's triangle, there will be a triangle area of subperiosteal new bone. Sun ray appearance. It will appear like sun rays. Irregular destruction. New bone formation in matrix of the tumor. Periosteal reaction, Codman triangle leading to new bone. Okay, then you have serum alkaline phosphatase SAP, which will be raised, and you can do fine needle aspiration cytology. So treatment, you have clinical suspicion. If there is there, then you take a local chest x-ray, local x-ray and a chest x-ray, and you do a biopsy to confirm the diagnosis. If the chest x-ray shows secondary, or the chest x-ray can be normal. If it is normal, you have to do local control. If it is not normal, you have to do local control first of all, and then you control the metastasis. Neoadjuvant chemotherapy, adjuvant chemotherapy, you have to do. You have to give chemotherapy no matter what. Then local control, you have to do ablation, limb surgery as given. Limb surgery you have to do as given here. Prognosis is good, patient uses artificial limb. And if you want a limb saving surgery, you have to do radical resection and reconstruction, arthrodesis and joint replacement. And this also prognosis is good. Arthrodesis is fusion of joint. You just fuse the joints here. My bad. I thought you have to amputate. This is actually fuse. Going on, chest X-ray, if it shows single on a CT scan, or it can be multiple, but if it's single, then you do resection of the secondary and treatment as in a local treatment you have to give, and prognosis is okay. However, if there is multiple, then you have to do palliative ablation of the tumor and chemotherapy. Prognosis is generally poor. So osteosarcoma, what you have to do for the surgery wise, you have lower end of the femur, you mid thigh amputation you have to do, and hip disarticulation you have to do. Upper end of the femur you have to do hip disarticulation, and hind quarter amputation you have to do. Upper end of tibia you have mid thigh amputation. Upper end of humerus you have 4/4 amputation. Lower end of femur, of course, mid thigh amputation, hip disarticulation. Upper end is hip disarticulation, hind quarter amputation. Upper end of tibia, then you have to do mid thigh amputation. Upper end of humerus, you have to do 4/4 amputation. 4/4 and hind quarter means you have to remove one leg or one arm. Hind is behind, 4 is front, and this is only for the early lesion. You do mid thigh, else you do entire hip disarticulation only. Then you have osteoclastoma. Chondrosarcoma, osteosarcoma. Osteoclastoma is also called as giant cell tumor. This even I didn't know. Osteoclastoma. Removing osteoclasts are removing the cells. That's why if you do giant cell tumor, is osteoclast will be increased. Osteosarcoma is bone forming tumor. Bone forming cells are increased. That's why there is osteosarcoma. I see. So going on, clinically, it may be seen in 20 to 40 years. That is after fusion of epiphyseal site. It can be from lower end of femur, upper end of tibia, upper end of fibula, lower end of radius, and lower end of ulna. All of these sites you can do. Tumor is located at the epiphysis. So examination, you have bony swelling, you have tenderness on palpation, and eggshell cracking can be seen. Radiological diagnosis, you have solitary lytic lesion of the bone will be there. Expansion of an overlying cortex can be seen. So therefore it can be an expansile lesion. Soap bubble appearance or loculated appearance can be seen, and there is no calcification within the tumor. Cortex is thinned out or perforated at some places. Cortex will be thin or perforated. So treatment is excision with reconstruction. You can fuse the joint with turnoplasty. You can fuse the joint by bridging the gap, or you can do arthroplasty. And you can also do amputation and radiotherapy for the treatment of osteoclastoma. So excision with reconstruction, arthrodesis by turnoplasty, bridging the gap, and orthoplasty. You can do amputation, you can do radiotherapy. Then you have Ewing sarcoma, wherein femur and tibia is affected. Pelvis and calcaneum may also be affected. So clinically, you have 10 to 20 years of age. The pain and swelling may be there, and there may be associated fever. Radiologically, you can have an oil pale appearance, and cortical destruction may be seen. Treatment, you give radiotherapy and chemotherapy, which is vincristine, cyclophosphamide, adriamycin. Vincristine, cyclophosphamide, adriamycin. So diaphysis of the long bones may be located in the metaphysis. There is very poor prognosis in this. Ewing sarcoma, femur and tibia is affected, pelvis and calcaneum is affected. 10 to 20 years of age, pain and swelling is there associated with fever. Oil pale appearance, cortical destruction. Radiotherapy or chemotherapy can be given. Osteoid osteoma is Partially mineralized osteotrabeculae surrounded by a dense sclerotic bone. Clinically, it is seen in 5 to 25 years, located in the diaphysis of long bones. There will be a nagging pain which is worse at night, and tenderness will be there at the site of the lesion. So X-ray, you can see zone of sclerosis surrounding a radiolucent nidus. Treatment, you do complete excision of nidus along with sclerotic bone. Then you have osteochondroma, which is the commonest benign tumor of the bone. Not a true neoplasm, its growth stops with cessation of growth at epiphyseal plate. At the epiphyseal plate, the growth will stop, then this also will stop. Therefore, it is not a true tumor. Commonest benign tumor. Pathogenesis, it is separation at the growth plate is seen, wherein there will be painless swelling around the joint, around the knee. There is limitation of joint movements due to mechanical block by the swelling. So there is a swelling, there is limited movement due to mechanical block. Treatment is excision including periosteum over the exostosis. So you have to do excision. Then you have simple bone cyst, which is a cavity in a bone lined by the membrane which contains serous fluid. Most common site is at the upper end of the humerus. X-ray, you will find well-defined lobulated radiolucent zone in metaphysis or diaphysis of the bone. So you have well-defined lobulated radiolucent zone in metaphysis or diaphysis of a bone. Then treatment can be methylprednisolone injection into the cyst you can do, and you can do curettage and bone grafting. So yeah, there's a table for revision of whatever we have done till now. There's a few more topics. Arthritis is important, gout is important, osteoarthritis is important, contractures are important. Actually, contractures not so much. Metabolic bone diseases is important, yeah. Rickets is most important. What is this? Okay. Then I guess that just leaked off my real name. My name is Abhinav, but again, thank God nothing much is leaked. Okay, so let's just revise this and move on. I'll revise this and stop. Actually, I have some things I need to do. So, okay. Osteosarcoma. This is between the age of 15 and 25, lower end of femur, upper end of tibia. It affects the metaphysis. Pain will be a lot, swelling will be a lot, and duration is for weeks to months. So you have sunray appearance, Codman's triangle will be there, and tumor new bone formation will be there. And differential diagnosis, Ewing sarcoma. It is a tumor with osteoid or bone formation. Alkaline phosphate will be increased in half of the cases. You have local ablation and chemotherapy. Then Ewing sarcoma between 5 and 15 years. Femur, tibia, flat bones are affected, and it may be multicentric. It is located in the diaphysis. Pain will be very much a lot. Swelling will be more. Often there is fever, and there is it lasts for weeks or months. Same as osteosarcoma, but there is often fever. onion peel appearances in whereas sundry appearance here it is onion peel. It may be osteosarcoma, osteomyelitis. So there are sheets of round cells, and radiotherapy and chemotherapy needs to be provided in Ewing's tumor, which affects the diaphysis. Then you have osteoclastoma between 20 to 40 years, lower end of femur, upper end of tibia, and lower end of radius. Same as above things that epiphyseal region it affects. Osteoclastoma affects the epiphyseal region. Pain will be less, not severe. Swelling will be less, but not severe. Duration it may last for months. Soap bubble appearance is there, and no tumor or no new bone formation is there. It can be aneurysmal bone cyst or fibrous dysplasia. There is multinucleated giant cells in fibroma of the stroma, in the fibrous stroma. Then you can do excision of the tumor with reconstruction to treat osteoclastoma. Excise the tumor and reconstruct it. Then chondrosarcoma, which is between 30 to 60 years old, affecting flat bone, upper end of femur. Okay, so anywhere in the bone it can be located, and clinically there is less pain, but there is the most maximum swelling, which lasts for, and it generally lasts for months, years. So there is moderate calcification within the tumor, and it can be mistaken for osteosarcoma. So you will have pathology of the chondroblasts and chondrous cartilaginous matrix. So you can do local ablation and you can do radiotherapy to treat it. Okay, so moving on, you have prolapsed intervertebral disc. Prolapsed intervertebral disc related anatomy, it can be consisting of three components: cartilaginous end plates, nucleus proptosis, and annular fibrosis. Nucleus proptosis, annular fibrosis, and cartilaginous end plate. Okay, this is actually okay. So pathology means protrusion or extrusion of the nucleus proptosis through a rent in annulus fibrosis. So there is a annulus fibrosis, and through the annulus fibrosis there is a rent. So sequence of changes lead to prolapse is first you have degeneration, then you have protrusion, then extrusion and sequestration. This is this thing. So clinical features, you have low backache, sciatic pain will be there, Cauda-Equina syndrome will be there, irregular lower motor neuron type paralysis in the lower limbs will be there. There is absent ankle jerks. Ankle jerks will be absent, and urinary and bowel incontinence may also be there. So again, low backache, sciatic pain, Cauda-Equina syndrome, lower paralysis, bilateral ankle jerks absent, urinary bowel incontinence. So examination, you have to check the posture. It may be rigid, flattened lumbar spine. The trunk is tilted to one side, which is sciatic tilt or scoliosis. Movements, you will not be able to bend forward. There may be tenderness in the lumbosacral region. There will be, so you can do straight leg raising test, which is positive at 40 or less, is suggestive of root compression. So investigations, you can do X-ray, myelography, CT, MRI, and electromyelography. So it can be differentiated as ankylosing spondylosis, vascular insufficiency, extradural tumor, and spinal tuberculosis. So treatment, you can provide rest, drugs can be provided, analgesics and muscle relaxants. Physiotherapy, you can do hot fermentation and gentle aching exercises. Lumbar traction can be provided. Cutaneous electrical nerve stimulation, TENS, can be done. So surgery, you have fenestration, laminotomy, hemilaminectomy, and laminectomy. You can do all of these surgeries. So Then you have causes of sciatica. It can be inflammatory or nerve root compression. So inflammatory, you can have sciatic neuritis or arachnoiditis, sciatic neuritis or arachidonitis. So compression in the vertebral canal may be there by the disc, by tumor or tuberculosis. All three can compress. So compression in the intervertebral foramen root canal stenosis will occur due to osteoarthritis, spondylolisthesis, facet arthropathy, and tumors. Compression in the buttock or pelvis can occur by abscess, tumor, and hematoma. All this will lead to compression in the buttock or pelvis, abscess, tumor, or hematoma. Then you have scoliosis or other spine deformities. Scoliosis is sideways curvature of the spine, which can be classified as non-structural or structural. Non-structural, you have postural, compensatory, and sciatic. Structural, you have idiopathic, congenital, paralytic, and neurofibromatosis. So pathologically, in lateral curvature of a part of spine, you have primary curve. If spine above or below the primary curve undergoes compensatory curvature in the opposite direction, it is secondary curves. Primary curve and secondary curves have been shown here. So curves in the curves of thoracic spine will lead to prominence of rib cage on convex side, giving rib hump. Rib hump will be there, and you will have rotation of vertebra also may be there, rotated vertebra. Okay, so X-ray, you can find Cobb's angle, the angle between the line passing through the margins of vertebra at ends of the cone curve. You can find, and you have rotation of vertebra. These kind of rotations you can see. Then treatment, you have non-operative and operative. In non-operative, you can give a Milwaukee brace and Boston brace, Reiter's turnbuckle cast, and localizer cast can be provided. And in operative methods, you have to fuse the spine. Then spondylolisthesis is forward displacement of vertebra over the one below it. Commonly, it occurs between L5-S1 or L4-L5. So type, it may be ischemic, dysplastic, degenerative, pathological, or traumatic. Ischemic, it can be dysplastic, degenerative, pathological, traumatic. So treatment, you have brace and spinal exercises. You have operative nerve decompression followed by fusion of affected segments, intertransverse fusion. So spondylolysis is the break in the pars articulations of one lumbar vertebra, commonly L5. Interarticulation of one lumbar vertebra, commonly L5, is spondylolysis. Spondylosis is degenerative process affecting vertebral disc and facet joint that gradually develops with age. Kyphosis is excessive backward convexity of the spine. It is of two types. It can be round or it can be angular. It is caused by postular, compensatory, Scheuermann's disease, or ankylosing spondylitis. Then related diseases, you have rheumatoid arthritis, which is I'll do rheumatoid arthritis onwards after some time actually. Yeah. So yeah, catch you guys in the next episode.